All of us are here.
Huh? All of you are here. Assalamualaikum warahmatullahi wabarakatuh. Let us begin our session with Ummul Kitab Al-Fatihah. Okay, the session this afternoon is long case presentation, isn't it? So who's presenting?
Me.
Niswa, okay. All right, okay. Let's go for it. Okay, wait. Before we go, as usual, if you have sessions with me, this is the typical. You guys, I think, should know already like what I expect. What do I expect from everyone? So presenter presents until summary. Kan? Lepas tu, what do I expect from everyone?
For each of us to
Comments.
comments.
Tak cukup kelas dengan aku lagi ni. So,
Comments with
provisional diagnosis, provisional diagnosis, differential diagnosis from her presentation. So what is your provisional diagnosis? You listen to her presentation. What is your provisional diagnosis? What are your differential diagnosis? If here I expect 5. Patut boleh vomit out 5 differential diagnosis and tell us why and why not. What are the positive and what are the negative points from her presentation? And then comment on her presentation. Comment meaning I don't accept things like baik, cemerlang, saya lah. No, I don't accept that. If you say it's good, bagus, baik, cemerlang, best, sedap, cukup masak ke apa, you kena bagi tahu why. Kenapa? Bagus sebab apa? Good sebab apa? Why? Tell us why. Tell the presenter why. Because when we know what is good, then we can improve on our goodness. Okay. And then if you think there are areas that can be improved, you tell her, tell everyone. So I think this area ni macam tak berapa best sikit, kurang masak sikit. So mungkin kena macam ni. I would prefer like this and this. Okay. Alright. So provisional, differential, at least 5, and then comment. Okay. Alright. Let's proceed with Niswa's presentation. Proceed. Tafadhal.
Okay, bismillahirrahmanirrahim. Assalamualaikum
Diagnosis
everyone.
bagi dah kat depan tu.
Sorry. sorry. Okay, bismillahirrahmanirrahim. So my chief complaint. Putra Muhammad Aiman, a 4-year-old Malay boy, was referred to hospital HTA for the complaint of dark color urine 2 days prior to the admission and sudden onset of facial swelling and abdominal distension on the day of the admission. Okay. For the history, 2 days prior to the admission, parents actually noticed that there is changes of the child's urine, whereby the urine become dark in color, almost black. And however, the parents deny any and then there is no pain during micturition. There is no other lower urinary tract symptoms such as hesitancy, urgency, or dribbling as well. And there is no frothy urine, and the parents say that there is a normal urine output for the child. And then, however, on the day of the admission, the father noticed that the child could have periorbital swelling and also abdominal distension upon awakening. However, the father denied of any presence of lower limb swelling, and there is no associated red discoloration of the skin or the lip. There is no warmness and also pain, and there is no history of insect bite or any insect bite seen, and also the patient has no known any allergies towards anything. Okay, all these symptoms is actually preceded by body rash 2 weeks ago, whereby it is described as generalized over the scalp, face, neck, trunk, and both upper and lower limb, meaning that all over the bodies lah. And the father said that the size is variables from 5 cents to 20 cent coin and characterized by red, macular shiny and also wet at the center part and crusted with crusted border. And the father said that it was itchy and tender because actually the child complained that he often scratched his body and pain upon touching of the rash. And the rash will bleed during playing. However, parents deny of seen any pus, fever, and there is no lethargy and there is no also upper and lower respiratory tract symptom. And for this rash, the parents said that they only give calamine, put the calamine lotion that available at home. And then on further questioning, the child actually had history of chicken pox 1 month prior to all these symptoms, including 2 of his siblings. And then they only went to the GP and then given calamine lotion. So the same calamine lotion was used to treat the previous rash. And the father said that the chicken pox has completely resolved and the current rash differs from his previous chicken pox rash. So, however, otherwise, there is no other associated symptoms such as headache and blurry of vision. There is no shortness of breath. There is no sleep disturbance such as inability to lie flat or being awakened due to the shortness of breath. There is no history of oral ulcer, any joint pain or malar rash. There is no history of easy bruising, joint pain as well as abdominal pain. And there is no preceded history of diarrhea, and there is no yellowish discoloration of the skin. And then for progression, after the father noticed that there is periorbital swelling as well as abdominal pain upon awakening, the parents immediately brought the child to the clinic kesihatan Kurnia, where a blood and urinary test was done, and it revealed some abnormalities as mentioned by the doctors, and then as well as there is a presence of high blood pressure. Therefore, the doctors referred the child to the HDA for further management. Okay, that's all for the history of presenting illness. And this is actually the patient's first hospitalization, and the patient has underlying eczema according to the father, which was diagnosed 2 years ago. And currently, there is no recent flares of the eczema, and there is no need of any admission due to that. And then birth history antenatally was uneventful. The patient the child was born at term via spontaneous vaginal delivery with birth weight of 2.5 kilogram. And postnatally, patient developed neonatal jaundice for 8 days and required phototherapy. However, the parents denied of any complication of the jaundice afterwards. And then the child was exclusively breastfed until age of 6 months old and completed weaning at the age of 2 years old. And currently, patient is eats a normal adult diet, which comprises of rice, soups, and also chickens or fish. Okay, there is no vegetable. And then this child is actually not fully immunized, in which his last immunization was the second booster of hepatitis B vaccination at the age of 1 month and has not taken other vaccination. However, from this there's no mention of any why the immunization history is not completed. There's not mention of any reason. And for the developmental history, it was up to his age. For motor, patient is able to walk and run up and down the steps, and patient has good tripod grasp and is able to color neatly, and he is able to cut a strip paper but is unable to follow the shape. And the patient also can name his home address and is able to tell a chronological story. He knows ABC and can count up to 10 but unable to read. And patient is able to dress himself and cooperate with his friend. For the family history, patient is the third child out of 4 siblings, which was ranged from 6 years old to 3 months old. His siblings are all alive and well, except for his younger sister at the age of 3 years, has a history of similar presentation last year and has resolved completely. And his father is 29 years old and his mother is 26 years old. Both have no non-medical illnesses. It is non-consanguineous marriage. There is no history of chronic illnesses run in the family, and his father works at a restaurant as an assistant, and his mother is a housewife. There's no history of autoimmune disease as well run in his family. Okay, that's all for the initial PI. Then proceed with physical examination. Generally, patient is alert and comfortable, look active with good hydration and nutrition status. There is a urine bottle with content of dark color urine at the overhead cabinet, and patient was generalized. There is a presence of generalized rash involving the scalp, back of the neck, trunk, upper and lower limbs. And the rash was variable in size, measuring 2 to 5 cm. It was described as macula with red and pale center with crusted border. However, there is no presence of facial puffiness or lower limb edema noticed. There is no jaundice and the patient was not pale. And there is no presence of injected throat as well. Peripheries are warm and capillary refill time is less than 2 seconds. Vital signs for blood pressure is high, which is 118/78 millimeter mercury. However, the other vital signs are normal. And anthropometric measurement, the weight is quite low, below third centile, which is 13.7 kilogram. Expected would be more 16 kilogram. And the height is the height is okay, 100 centimeter. For abdominal examination, on inspection, the abdomen was distended and the umbilicus was flat, but it moved with respiration. On palpation, the abdomen was soft and non-tender, but there is no palpable liver or spleen. Percussion, there is presence of positive shifting dullness. However, there is no presence of any fluid trail. And there is no evidence of pulmonary edema as well as pleural effusion. The other system, such as cardiovascular and neurological, also unremarkable. For summary, my patient, 4 years old Malay boy, was presented with sudden onset, with 2 days with sudden onset of abdominal distension and also periorbital edema, with 2 days history of black color urine preceded by the rashes 2 weeks ago. However, on examination revealed that there is abdominal distension with generous body rash with abdominal distension. Okay. With high blood pressure. Strategi with high blood pressure.
Okay, done.
Done.
Okay, let us go to your colleagues. Okay, again, what I want is first provisional diagnosis. What are the differential diagnosis that you think from Niswa's presentation? Provisional, differential, and then comment on her presentation. If good, why do you think it's good? Where do you think she can improve on her presentation? Okay, how we'll go about it? From my screen here, the first one will be Aklan, and then Shamimi, and then Zafirah. Lepas Zafirah, Jazli. Lepas Jazli, Nur Anisah. Lepas tu Nur Akilah. Lepas tu Nur Hazirah. Lepas tu Anis. Lepas tu Solhi. Okay, alright. Okay, let's go. Aklan. Provisional differential comment.
Based on Niswa's presentation just now, my provisional for this case would be post-Streptococcal glomerulonephritis. The points for this diagnosis would be the patient's complaints of symptoms of hematuria, and patient have periorbital swelling. And also patient is preceded by apparently a skin infection about a week ago, which is described as macular rash with some crusting of the skin. So it might suggest an impetigo, which is like a preceding event before the PSGN can occur. My differentials for this case would be Hemolytic purpura nephritis. However, based on Niswa's presentations, she did not mention of any the gravity-dependent palpable purpura, which is a characteristic of HSP. And also patients did not complain of any bowel angina to suggest such presentation. My other differentials for this case would be lupus nephritis, secondary to SLE. However, based on epidemiologically, it is less common in younger age group and also in boys in particular. as this case is actually a 4-year-old boy. And also from symptomology, actually patient have no oral ulcers, patient have no malar rash, and also no arthritis to begin with. My other differentials for this case would be IgA nephropathy. However, this one I cannot really rule in or rule out because Niswa did not mention of any like previous recurrent episodes of hematuria always following after infection of URTI. So I think that can be included in the presentation.
Well, IgA nephropathy, it can be the first onset, isn't it?
So, okay. And then my other differentials for this case would be subclinical and infective endocarditis, but I think based on this first presentation, patient have no previous underlying congenital heart disease, any instrumentations of the cardiac, there was not such history. I think that's all for my provisional and my differential. As for the comments, I think for the points, the good points for Niswa's presentation is that she presented in a chronological manner. I mean, like every symptoms was well elaborated in detail. So she started with the elaborations of the hematuria, elaborations of the edema, and also she mentioned of the preceding rash. And also she already ruled out all the complications of PSGN, in which she mentioned that the patient have no headache, blurred visions, which I think she are trying to rule out the hypertensive encephalopathy. And also she mentioned that the patient have no SOB, so she's already ruling out acute pulmonary edema, and patient have no failure symptoms. However, and then after that, Niswa also ruled out the SLE, the possible, she mentioned that the patient have no SLE symptom, no history of, I think, but I think the things that it's just a nitpicking actually. I think she can rule out the differentials before ruling out the complication. I think that's more like a preferable manner. Like she mentioned of the provisional, she ruled out all the differential first, only then she ruled out the complication. I think that's a much better, but it's more of a nitpicking minor point, I think. That's all from.
Okay, all right. That is not compulsory lah. It's actually it's up to you. You nak buat kaki kat atas, kepala kat bawah pun it's okay as long as you complete. Cumanya orang stress lah dengar. If you letak kaki kat atas, kepala kat bawah kan, orang stress dengar. Your punya examiner pun sometimes dia pun tak perasan. So it's okay. Yang penting ada lah. But if you organize, for me the most important thing is you organize your presentation according to timeline, chronological order. That is much more important. Okay, all right, Shamimi. Yes, let's hear from you.
Yes, so for my provisional diagnosis, same as explained, is this post-streptococcal glomerulonephritis because of the presence of the rash, hematuria, and also edema. And for my differential diagnosis, I would like to add some point from Makan, which is I would like to add urinary tract infection because of the hematuria. And then I would like to add, but in this patient there is no urinary tract symptoms. And also I would like to suggest the second one is bleeding disorder, like ITP. But in this patient there is no symptoms of bleeding disorder, like bleeding tendency. And then the third one is Hematuria purpura, and then Alport syndrome. And then for Alport syndrome, I think Niswa should ask in the family history whether there is family history of same symptom like the patient currently.
There is kan, seorang, another sibling that had similar symptoms at 3 years old. Cuma Niswa tak cakap yang ada sibling tu gender dia apa. Is it important to know the gender of the other sibling?
Yes. Because the Alport syndrome is at X-linked.
Yes. Sayalah Shamimi. Do you know Niswa? Tahu ke tak tahu yang gender yang sibling itu?
Oh, yeah.
Sudah Niswa. Tahu tak tahu? Ada idea?
Younger sister tu. Younger sister. So possible lah.
Possible? Okay.
Then the last differential is lupus nephritis. Okay. Because of the presence of the rash. and hematuria. And for the comment, I would like to suggest Niswa to add some exothermia symptom such as nausea and vomiting. If I'm not mistaken, Niswa did not mention about the exothermia symptoms. And then I would like to suggest if Niswa can add rule out the other diet history, rule out the beetroot consumption, because beetroot also can cause dark colored urine. And then
Cumanya Syamimi, orang Malaysia makan beetroot tak?
jarang
Tak kan? Kalau dekat certain countries, macam kat UK, dia punya sugar dia is beetroot punya sugar. So rasa dia lain tau. Kita pakai gula sugar cane kan? Tapi kalau kat UK dia pakai beetroot punya sugar. Tapi beetroot punya sugar doesn't cause this discoloration lah. But beetroot is not easily available kat Malaysia lah. TMG tak ada jual. Tak tahulah kalau Pak you punya kampung ada jual.
And then I would like to suggest if Niswa can emphasize on the history of catheterization if there is any.
History of apa?
Catheterization, urinary catheterization, because urinary catheterization can cause hematuria as well.
Okay.
And that's all for the comment.
Okay. Zafira.
Okay, so from this presentation, my provisional diagnosis is post-streptococcal glomerulonephritis because okay, the first my provisional diagnosis is post-streptococcal glomerulonephritis because of presence of hematuria and periorbital swelling, which indicates edema, and then like cancer is preceded by skin infection 2 weeks ago, and then the second one is the like my differential diagnosis. The first one is purpura nephritis because there is presence of rash over because Niswa said that the HOPI is the rash only. He doesn't say about purpura or petechiae or even the describe of the rash is not mention more about that. And then he also and then next one is the next differential diagnosis is I would like to rule out any other nephritic syndrome because this patient had hematuria and then edema as well as increased blood pressure, which is hypertension. So it more towards the nephritic syndrome. So I would try to rule out IgA nephropathy and anti-glomerular basement membrane disease such as Goodpasture syndrome. And so Goodpasture syndrome, so I would like to know if there is any hemoptysis because it happens also in pulmonary hemorrhage. And then next one is the SLE because SLE also can have nephritis. But there is no symptoms suggestive of ulcer, alopecia, or any arthritis and so on. And next one, because of presence of hematuria and preceded by rash, preceded by infection before, I think like Mimi said, idiopathic thrombocytopenic purpura because it can present with hematuria too. I think that's all for my DTS, and that's my comment for Niswa. The first one, I think it is good because I think Niswa had rule out most of the diagnosis, differential diagnosis, even differential diagnosis, and what Niswa can improve from the this presentation is I think Niswa didn't mention about social history, so we do not know how the financial status of this patient, the support, and then so on. But and then the next one is I think I'm not mistaken in PE about the rash is not like not described well lah. I think because this is from the case right up, so it's okay. That's all from me.
Okay, alright. Next is Jazli. Dia dah berubah aturan ni. Jazli, lepas tu Anisah, lepas tu Akilah, lepas tu Hazirah, lepas tu Anis dan Solihi Jazli.
Okay, Assalamualaikum doktor. My name is Jazli. So regarding this case, my professional diagnosis would be post-streptococcal glomerulonephritis, evidenced by the what I have Niswa mentioned, the hematuria, and it's a classical symptom whereby we have infection prior to that, where patient have the rash and generalized rash, which is itchy and urticaria. Patient, apart from that, patient presented with the periorbital swelling and generalized swelling. All are symptoms of post-streptococcal glomerulonephritis. Apart from that, my differential will be as what I've mentioned previously, which is Hemolytic purpura.
Henoxon line. Bukan Henoxskulin. Henoxon line.
Henoxon line. Henoxon line.
Henoxon line. Sean line.
Henoxon line. Okay. Okay. Henoxon line purpura. Because of the presence of the rash. And however, I suggest that Henoxon line purpura because of evidence of the rash, and then there's hematuria, which could be a symptom of Henoxon line purpura because it have renal involvement. Apart from that, one of the important thing to rule out when we mention about HSP is ITP because of the presence of rash, and patient also have history of prior infection, which could be the rash. Apart from that would be lupus nephritis, but it's not really common in this age. But patient presented with the hematuria, and patient have the periorbital swelling, generalized periorbital swelling and abdominal swelling. Okay. My comments for the presentation is that I think Nisa did well because the flow is quite clear because the patient came with evidence of the swelling, and apart from that, he has a history of rash and it's very pathognomonic presentation for post-streptococcal glomerulonephritis. But my suggestion is that for improvement, my suggestion maybe when mentioning about periorbital swelling, Niswa mentioned about there is no history of insect bite and others. I suggest to rule out acute differential, which could be anaphylactic reaction from maybe patient have history of maybe patient have SOB with that presentation or what, because patient come with the periorbital swelling. So we worried that patient could have SOB or anything more acute. Apart from that, especially I would suggest, if possible, to emphasize on how does this pathology affect the child, because in my experience, some cases the child is unable to go to schools for weeks because of the treatment in this case. So maybe ask about absenteeism, how is the child being taken care of, how frequent he have to miss class because of the sickness. I think that's it.
Okay, all right. Next, let's go to Nur Anisa.
So my provisional diagnosis for this patient is post-streptococcal glomerulonephritis because this patient presented with hematuria and as well as periorbital edema, which support the PSGN. And there was also history of rash, which I believe to be impetigo, as well as chickenpox. And then from the PE itself, there was a presence of urine pot containing the hematuria, and then distended abdomen and also high BP. and also presence of the rash. And for differential diagnosis, I would suggest HSP.
Wait,
Not
Anissa, no, Anissa. How high was the blood pressure?
high. I think upper border of 95% based on age.
Are you sure?
I checked just now on PRITS protocol. It say at 95%. Yeah.
What's the blood pressure again, Niswa?
118/78.
118/78. Okay. Fine.
Supposed to be 113 at 95 percentile.
The only problem with that is, but anyway, dia akan jadi high juga lah. The only problem with that is, Niswa presented the height, but she didn't say the height is at which centile.
Yeah.
Kan? So kalau you tengok ni, okay, let's see. If you see PITS protocol, kan, if you see PITS protocol, to look at the centile, to look at the height, to look at the BP, you need to look at the height centile kan. So kalau height dia above 95%, baru dia akan, tapi dia 118, so memang high lah. So it will be here kan. So this is height in centile 50th and 95, and then yang ni dia punya ni lah, dia punya BP dia. Okay, alright. Okay, next. Continue, Anissa.
My differential diagnosis is the first is HSP, not Schollin purpura. It's called Schollin purpura. Because of the presentation of hematuria as well as the rash. However, the rash doesn't meet the criteria of the HSP itself because HSP usually presented with purpura. And then the second is SLE or SLE nephritis because the presence of hematuria and also the rash. However, there was no any other symptom that meet the SLE, like no malar rash, no joint pain. Okay, and then the third is it could be to the infection. However, the presenter deny any infective symptom like dysuria or any urinary symptom, other urinary symptom. And the next is would be any hemoglobinopathy or any like sickle cell disease, but the presenter also deny any bleeding tendency. And the last would be, although it might be rare, but we could also consider any malignancy cause such as Wilms tumor. Maybe the presenter can ask about any primary history of malignancy and also any constitutional symptom. Okay. For the improvement, the presenter did well, I think, because the history is in a good okay, the presenter present well in a good chronology, and then however from the history itself, maybe she can add about the presence of joint pain, because in HSP and also SLE, it was quite a significant history also. And then for PE, maybe she can add about I think about the what we call it, the nephrotic punya chart, if there is any lah. Not nephrotic chart, the Hematuria chat. Okay. That's all.
Okay, fine. Akilah.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So from Niswa's presentation earlier, my provisional diagnosis will be post-streptococcal glomerulonephritis as evidenced by the presence of edema manifested by periorbital swelling and also abdominal extension, which is preceded or associated with dark colored urine, which could possibly be hematuria. But from that, on physical examination, patient also has hypertension, and with history of preceded by presumed skin infection manifested as rash, which could be impetigo,
which is the risk factor for patient to develop post-streptococcal glomerulonephritis. So as for my differential diagnosis, the first one could be Henoch-Schwann line purpura nephritis, as evidenced by the presence of hematuria, and also could possibly be due to the edema could due to AKI, secondary acute kidney injury, secondary to SSP nephritis. However, the negative point would be that there is no history of joint pain, arthralgia, or bowel angina, which could be manifested as abdominal pain or parietal bleeding. My other differential would be SLE nephritis, due to the presence of symptoms suggestive of acute kidney injury such as the edema and also due to the hematuria. However, patient denied other history of SLE. And also, Niswa mentions that there is no family history of autoimmune disorder. And also, it is less common in boy instead of girl. This patient is a boy. Okay. So my next differential would be other causes of acute nephritic syndrome such as IgA nephropathy or subacute bacterial endocarditis, like what Aklan has mentioned previously. My other differential could also be hemolytic uremic syndrome due to the presence of dark colored urine, which can also probably be due to intravascular hemolysis, secondary to microangiopathic hemolytic anemia in HUS, and also due to the presence of AKI, which is manifested in HUS. However, the negative point would be that there is no yellowish discoloration as noted in history or even in physical examination. There is also no history of prior gastrointestinal infection. Apart from that, my other differential diagnosis could also be urinary tract infection or even renal stone or urolithiasis. However, patient had no fever and there is no other lower urinary tract symptom. I'm not sure whether Niswa mentions if there is any presence of loin pain to suggest pyelonephritis or venous stone. Okay, so that is for my differential diagnosis. And for improvement, I think Niswa did well in delivering the history to suggest the provisional diagnosis, which is probably the post-streptococcal glomerulonephritis, and also she presented in a chronological manner. However, I think Niswa could improve more, in which because in this case, her chief complaint would be probably hematuria due to the presence of dark colored urine. So I think it is also worth noted for Niswa to mention if there is any other bleeding tendency to rule out if this is any systemic cause of bleeding disorder. And also, Niswa could also mention about drug history, for example, the antiplatelet and also anticoagulant, which also could predispose to patient having hematuria, as well as underlying patient's underlying bleeding disorder or family history of bleeding disorder. And apart from that, I think Niswa did well in ruling out from the history her other differential diagnosis such as SLE or HSP. However, the other signs of the differential diagnosis were not deliberately mentioned in the physical examination. For example, she did comment on patient having the skin rash to suggest impetigo, which patient has, but she does not rule out other sign for other differential diagnosis, such as she could also comment on whether patient has no oral ulcer, no alopecia, no malar rash, and so on. I think that's it. Thank you.
Okay, good. Next, Hazira.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So for this patient, my provisional diagnosis would be post-streptococcal glomerulonephritis because this patient is presented with edema and also that dark colored urine could be hematuria, and also it is preceded by history of rash 40 weeks ago. And in the physical examination, there is also hypertension. For my differential diagnosis, I would like to rule out the other primary causes of acute glomerulonephritis such as IgA nephropathy because of edema and hematuria. And also I would like to rule out HSP nephritis because of edema and also hematuria. But in this patient, there is no palpable purpura. And then the differential diagnosis could be lupus nephritis because of edema and also hematuria, but there was no malar rash, oral ulcer, alopecia, or arthralgia. And for the causes of hematuria, the other differential diagnosis could be urinary tract infection or urolithiasis but this patient did not present with other history of urinary tract symptoms. Okay, and then for the comment for Niswa's presentation, I think she did very good because she present in chronological order, and first and foremost she present the current symptoms before she proceed, followed by the preceding symptoms of rash and so on, and then she also explained about the complication and all. But for improvement, I'm not sure whether Niswa has emphasized that this is the first episode. There is no history of the same complaint before. There is no episode before. So and then for complication, I think Niswa can add about uremic symptoms such as pruritus, nausea, and also vomiting. So I think that's all.
Yang sebelah-sebelah bilik ke? Ha? Ya? Okay, alright. Anis.
Assalamualaikum. Can you hear me clearly tak? Okay, so my for this case, my provisional diagnosis is post-tract glomerulonephritis because it is the most commonest cause of patient that comes with hematuria and also edema. So in this patient, the positive findings that from the Hematuria, there is hematuria and also features of edema, for example, periodic swelling also at the midline.
Anis. Tak berapa dengar apa you cakap. Lepas tu sebab kamera memandang ke atas, so we cannot decipher what they are trying to say.
Dengar ke kata?
Ha?
Can you hear me now?
Sekarang better tapi nampak dahi je. It's not that we want to look at your face lah, tapi sometimes kalau bunyi tak apa clear, kalau kita nampak what they're trying to say, kita boleh decipher at least apa.
Okay, if I want it to be clear, I need to be closer to the speaker. Sorry. Okay, sorry. So for PSGN, other than hematuria and also edema, there's also history of skin infection prior to this hematuria and also edema, which is suggestive of strep infection, and there is also history of chickenpox 2 weeks previously that could be a secondary infection later because of strep. So and also the patient had hypertension, and the negative finding, the patient, there is no history of UITI, which could be a source of infection for strep also, and also there is no oliguria, I think, which is a feature of PSGN. Okay, so second is Hematuria purpura, because this patient had rash, which is the Niswa I mentioned that the rash is systemic, it involves generalized all over the body. However, HSP Hematuria purpura usually is palpable purpura, but in this patient it is and also only located to the lower limb. But then in this patient it is generalized. And
Anis,
more to like
what did you say? Distribution of rash for HSP again?
From what I know, for HSP, the distribution is more towards you said that the gravity dependent area, for example, like buttock and also ankles and also lower limbs lah. Usually involves more towards the lower limbs. Okay. 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 That is the second differential. The third one is subclinical bacterial infective endocarditis. This patient had features hematuria, but then there is no features of like palpitation, and also on examination there is no feature of murmur, and there is no history of congenital heart disease. Other than that, SLE. But then this patient is a male, and also there is no family history of autoimmune, and also there is no other features of SLE other than the hematuria. And the last one is immune thrombocytopenic purpura, ITP. Okay. This patient had rash and also features of glomerulonephritis, and it is he is in a common age to get ITP, but then There is no family history to suggest that immune mediated disease in the family. Okay. So for the good thing about Niswa's presentation is that her presentation is very clear and also with good tempo. I don't really become lost lah during her presentation. And then she also have ruled out the important points such as the complication, which is dangerous if we miss it, for example, pulmonary edema and also encephalopathy. And for the what can be improved, because in the physical examination, I think she didn't mention about other systems other than just the rash and so on. So also we need to look at the astraja and arthritis. And also for the history about the immunization, probably because this is just right out, but then if she like the patient, probably she need to inquire further about why the patient does not have vaccination up to 6 weeks. Okay. And also about the developmental history, I think even though she said that the development is up to age, but then she elaborate what she asked to the patient. So that is okay. That's all. Thank you.
Okay, good. Solhi. Oh, Solhi dah ready. Yes.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So based on this first presentation, I would like to consider post-strep PSGN. Firstly, because the patient presented with dark-colored urine, which might suggest hematuria, and the patient also have a facial puffiness, which is edema, and also on physical examination, there's hypertension, 118/78, and there's also pre-existing skin lesion, which might suggest impetigo. So otherwise, there's no mentioning of reduced urine output and so on, the negative point. So my differential diagnosis, first I would like to consider other causes of primary acute glomerulonephritis.
Solhi, she did say urine output is normal.
Oh, okay, sorry, I missed that. Okay. So I would like to, for differential diagnosis, I would like to consider other causes of acute glomerulonephritis such as IgA nephropathy and also Goodpasture syndrome. So specifically for Goodpasture syndrome, there's no mentioning of coughing out of blood, which is maybe the manifestation of pulmonary hemorrhage. And my next differential diagnosis, I would like to also consider hemolytic uremic syndrome, in which the patient presented with hematuria. However, there's no mentioning of there was no diarrhea, no abdominal pain, and so on. So another differential diagnosis that I would like to also consider is HSP, Hematuria purpura, because the patient presented with hematuria and rash. But there was no gravity-dependent purpura, and there was no bowel angina or arthralgia. So other differential, might also consider SLE, lupus nephritis. However, there's no symptoms to suggest SLE, such as alopecia. In fact, the patient is a male, and there's no joint pain, no oral ulcer. And other than that, maybe there's one more rare disease that you might, since everybody is mentioning probably the same differential diagnosis, I would like to also suggest one rare disease, which is Redness Granulomatosis, or the new name is polyangiitis, granulomatous with polyangiitis. But for this diagnosis, you need to ask more regarding the recurrent history of recurrent sinusitis, or eye symptoms such as conjunctivitis, episcleritis, and on physical examination, there might be saddle nose deformity because of the presence of hole in the nose septum. But this is very rare. For comment, I think Niswa did well in terms of presentation. Just a clear flow. I can clear flow. Everything is chronological order. Complication is very well dig into. But for improvement, I think she needs to elaborate more in terms of social history. And I think many of us undermine the importance of social history. Medical students can relate very well into that. Because in pediatrics patient, you need to consider that they are in school age and so on. So if they get sick, then of course it will affect their their studies and so on. And also you need to ask about the social support, parents' expectation, concerns, and so on. And that's also when you ask things like this, it will give a good impression to the examiner that you are an empathic doctor. I guess that's all. Thank you.
Not just that, we need to know about the living conditions as well. So this child had one had just recovered from chickenpox 1 month ago, and then now complicated with some other skin lesion. Could be impetigo, could it be scarlet fever? Could be, we are not sure. Sounds like impetigo, but then with the whole impetigo involving the whole body. And then, so how is the living condition? How many people living in the house? So all these things are things that we need to actually look into. Okay, Niswa. Before I give my comments on your presentation, let's hear what are your provisional and what are your differentials.
Okay. So from history and physical examination just now, so my provisional diagnosis would be post-streptococcal glomerulonephritis, as this patient had sudden onset of swelling, periorbital swelling and abdominal distension, and 2 days history of probable hematuria because of the dark color urine, and then preceded by 2 weeks of skin rash, or might be streptococcal causes from the streptococcus. And then from physical examination, there is presence of high blood pressure with abdominal distension, and also presence of urine pot containing the dark color urine. And then my second differential diagnosis, I think of HSP, Scholin purpura, because of presence of the prior infection with tender rash, as mentioned from the as the child said that it was tender, and then with presence of hematuria as well as edema. However, there is no presence of palpable rash with joint pain and also abdominal pain. And my second differential diagnosis would be any
Niswa. If you're thinking about HSP, you said HSP has abdominal pain. If HSP has abdominal pain, what has happened?
Ya, apa tu? Ischemia, bowel.
Sebelum bowel ischemia?
Interception.
So in HSP yang selalu jadi is intermittent interception. So kejap-kejap dia masuk, and then kejap-kejap dia release. Kejap dia masuk, dia release. So this is typical of HSP. Okay, alright. Proceed.
In it, think of any acute nephritic syndrome such as IgA nephropathy and also Alport syndrome tu boleh masuk kat tu. Because the younger sister also had resistant presentation previously, and the patient himself have edema and also hematuria. And then I would think also
Alport usually is more of male lah. Tapi kalau if you have a macam ni, ada several family members having renal failure, so you need to think about Alport syndrome. But generally Alport is affected male more than female. Okay, right.
Then I'll think of SLE as well, systemic lupus erythematosus, causing nephritic syndrome, but it's less likely to occur in boys, and also there's no other symptom of SLE such as oral ulcer, malaria, as well as alopecia. And then I'll think of HUS also, hemolytic uremic syndromes. But
in your presentation you didn't rule out HUS.
Tak pun. Tapi cakap je tak ada. There is no GI infection preceded by GI infection as well as yellowish discoloration.
Okay.
Okay. And then lastly, I would also
about HUS. So if you're thinking about HUS, there's another thing that you should have presented actually that I expected a bit more. Condition of patient on admission. So because HUS, usually patient will be very ill, septic looking. And so what's the condition of the patient on admission? Do you know what condition of the patient? So you presented history, and then you present yang physical examination kan? Tapi that physical examination is the physical examination during your examination. But one thing that is not dwelt enough in your history is the condition of the patient on admission. Maknanya father bawa hari tu sebab dia start ada periorbital puffiness and abdominal distension kan. But before father brought the child to the hospital, what was the condition? Was the child already getting worse in terms of more irritable, feverish ke, nampak more ill looking, lethargic, malaise ke?
Dehydrated.
whatever. So what is the condition of the patient, status of the patient on admission dekat ED tu. Sebab HUS you would expect the child to come in quite ill kan, and then it takes time. And then you tak cerita pun, bukan you lah, orang yang examine this patient ni, they examine ni which day of admission. Could be they examine ni dah day 5, day 130 of admission ke, we don't know kan. So day of examination, when is the time of examination of clerking as in comparison to the time to the day of admission is, I think, is important. Okay, alright, lagi.
And then lastly, I would think of any UTI, urinary tract infection as well as stool. However, the patient did not complain of any urinary tract infection symptom, but I didn't ask about the loin pain for the stool. And then that's all for my provisional and differential diagnosis.
Okay, could it be nephrotic syndrome? Boleh jadi nephrotic syndrome tak?
Boleh.
Can.
Boleh.
Why and why not?
The patient presented with edema. The presence of edema, however, the patient did not have but the blood pressure, high blood pressure.
Okay, blood pressure. Okay, we'll go about that blood pressure issue. Okay. What else? Siapa lagi nak try cakap? Solhi ke siapa try nak cakap? Jasli. Why not?
Why not? Because there's two theory for the nephrotic syndrome. One is overfill and another is underfill.
Okay.
So based on the underfill theory, by right, the patient should not have the blood pressure should be normotensive. However, in case of overfill theory,
normotensive or low lah.
Normotensive or low. However, in case of overfill theory, the sequelae of which could be from a sequelae of the underfill or anything that can cause the activation of the RAS system. So in this case, a patient could have nephrotic with hypertension.
Yeah, so in nephrotic you can have both. You can have both normotension or hypotension, and also hypertension as well with the activation of RAS. Kan? And satu lagi from history tak ada frothy urine kan? Okay, can nephrotic syndrome present with hematuria? Anissa.
Lepas tu Anissa.
Yes, if there is nephrotic syndrome.
Yes, nephrotic syndrome. Very true. Tapi selalu can ni is not a good question lah. If I ask can, the answer is 99.9% is can lah kan. Okay, so nephrotic syndrome. So a patient can have both features of nephrotic and features of nephritic syndrome as well. Okay, alright. Can it be liver? Niswa, do you think can it be liver? Can. So can is not a good question. If I ask can, the answer should be can lah. Okay. So why and why not?
Liver problem can also manifest as fluid overload, which is edema, and probably the hematuria could be the manifestation of coagulopathy secondary to the chronic liver disease.
Oh yes, very true. Why not? What are the negatives?
There is no yellowish discoloration, no jaundice.
Dia cakap no yellowish discoloration. Ada cakap? Tak ada juga. Okay, fine. Okay, lagi?
No, I'm not sure whether she mentions about any abdominal pain, and also no, I'm not sure whether Niswa mentioned about the risk factor for patient to develop chronic liver disease, and also on physical examination, I think she also does not mention about the stigmata of chronic liver disease specifically.
Yes, okay, stigmata of chronic liver disease. Okay, Akilah mentioned about abdominal pain. Abdominal pain is very important, especially if you think about the difference that we spoke about just now. Nephrotic syndrome, nephritic, kalau ada abdominal pain. what is the thing that you need to think of? Nephrotic abdominal pain. Spontaneous bacterial peritonitis is among the worst complication of nephrotic syndrome kan. So spontaneous bacterial peritonitis. So dia di antara benda kita nak kena cover. So liver can be a problem. So you need to think. So anybody presented with edema, you need to think of all these things, termasuk liver. Cardiac, I think you've ruled out cardiac as well kan. So cardiac, I think she's ruled out most of the things in relation to cardiac, tak ada failure symptoms, blah blah blah. So renal, liver, cardiac. So edema, you need to think of all these things. Satu lagi, can it be caused by something that he ate? Anyone knows any specific food that can cause nephropathy? Bukan McD, bukan KFC, one specific food yang boleh cause nephropathy.
Drug or food.
Petai ke doktor?
Petai.
Pernah dengar. Petai.
Bukan, lebih kurang. Bau lebih kurang sama. Jering, yes. So jering. So jering ni jengkol lah kan. So the English term is jengkol nephropathy. Jengkol ni bahasa Indonesia. Lepas tu basically Dutch lah kan. Dutch kan dia panggil jengkol. So jering is jengkol. DJENGKOL, jengkol. So jengkol nephropathy is a known disease lah kan. I've seen one. I've seen several. I think 2. Jengkol nephropathy. Not in children, in adult. Orang zaman sekarang ni tak makan jering pun. Your batch mungkin tak kenal pun jering macam mana rupa dia. Tak tahu lah orang sekarang ni tak makan jering kan. So jering is a known cause for nephropathy. Okay, any drug that can cause nephropathy?
Is inhibitor.
Nephropathy.
Nephropathy.
Methotrexate.
Oh, aspirin.
Methotrexate, yes. Methotrexate. Yep. Okay. All right. Let us go back to Niswa. Niswa. Oh, tapi tak nak Niswa, kan nak suruh orang lain Siapa yang bertuah? Syamimi lah. Syamimi. Even though Niswa yang present, dia dah baca dah. So, if you are the doctor on call at that night, seeing this patient upon admission, tell us, how would you manage the patient? How would you investigate and manage this patient?
For the investigation, this patient, first I would like to do urine analysis in order to look for the presence of proteinuria. And also presence of hematuria by the presence of the red blood cell counts. And then I will also do the whole blood count. In order
Syamimi, you won't see red cell counts on urinalysis. Urinalysis is just the spectrometer, kan? You boleh tengok ada RBC tak. You won't see CAS. Macam mana tengok CAS? Untuk CAS, you kena hantar FEME lah, full examination and microscopic examination. Urinalysis is just the spectrometer tu. Okay, alright, proceed.
And then I would like to do a full blood count in order to look for anemia because the patient presents with hematuria. And then I would like to look for the white blood cell count for evidence of infection in case this patient have urinary tract infection. And then I would like to order in order to detect the presence of the antecedent streptococcal infection. I would like to order anti-streptolysin O titer in this patient to know whether the patient is infected by the streptococcal before. And then I would like to do the renal function test to look at the status of the renal, whether the patient have renal injury or not based on the creatinine and also urea. And then I would like to do the complement level, C3 and C4. C3 and C4 will be low in the initial presentation of the nephrotic syndrome. And later, C4 will be normalized and only C3 will be low for the nephrotic syndrome. And then I would like to do the ultrasound of the kidney in order to know whether there is presentation of the stone in the kidney. And that's all.
Is that all? Investigation? Done. Cukup. Anything else? Anyone has any idea other investigation that we can do?
Chest X-ray, because acute pulmonary edema is one of the complications.
Okay, if you think there is so you chest X-ray because it's radiation, so you need to think of whether it is beneficial or not for you to expose the patient to extra radiation. Sama juga tadi you nak buat ultrasound nak tengok renal stone. Kan, the easiest imaging to assess renal stone is actually KUB X-ray kan. Tapi again you need to think lah why. Actually there is another reason for you why you should do ultrasound. You need to look for something else. Anyone has any idea? Size at the kidney, look for renal parenchymal disease. Lagi apa lagi? Ultrasound ni apa something yang you nak tengok, you nak kena send something untuk ultrasound. Blood pressure, high blood pressure punya issue.
Polycystic
hydronephrosis.
Autosomal recessive polycystic kidney.
Doppler, you nak look for renal Doppler, renal artery Doppler. Look for renal artery stenosis because you know renal artery stenosis can cause hypertension. Okay, any other investigation? If the child has urea is high, creatinine is high, what else you want to send? Blood gas. Look at blood gas as well. Look at the acidity, bicarb level. Our differential lagi tadi apa? Liver. So you look at LFT. You tengok albumin level dia macam mana. Kan?
Doctor, may I ask? For
Yes.
ABG, we want to see whether the patient have acidosis, ke doctor?
Yes, look at the pH level, bicarb and base excess.
Oh, because we worry of metabolic acidosis.
Because of renal impairment.
Oh, renal impairment. Oh.
Okay, siapa pula? Siapa ya? Akilah lah. Oh, Akilah. Okay, how would you manage this patient?
First, as for other management, I would like to stabilize the airway breathing and also circulation, maintain the patency of the airway, secure airway, ensure adequate breathing, and also ensure adequate circulation. I would insert 2 large bore granula and also take the necessary blood investigation. So as for Echang, I would insert the
Why 2 large bore cannula?
For adequate fluid resuscitation.
You want to give fluid to this patient?
No. At this point of time, no.
So why you want to put 2 large bore cannula? Dengar orang lain cakap.
Because if patient develop complication.
Okay, what complication? What are you thinking about ni?
For example, patient can also develop secondary to hypertension. Patient can also develop heart failure. In case of heart failure, we should administer, for example, inotropes. I think so. We need good access.
A better answer should be because the patient is hypertensive. So if the patient goes into hypertensive crisis, you need an extra line for you to give some other medication macam tu. Tapi you need to remember lah, high blood pressure, if you struggle putting lines in, BP dia akan jadi lagi tinggi. So not all patient you need to put 2 large bore cannula. Putting large bore cannulas on children is already difficult. So if you want to put 2 large bore cannulas, you need to think why you want to put 2 large bore cannulas. Okay, alright. Jangan copy paste je. Okay. Yes.
And then apart from that, I would like to do street input-output charting, put patient on urinary catheter, and also put patient on nephrotic chart, which would measure the urea output, daily weight, also BP charting. Apart from that, in case of post-streptococcal glomerulonephritis, I would also aim to eliminate the group A beta hemolytic streptococcal infection by giving patient penicillin B for 10 days duration. If it is contraindicated in the patient, we can opt for the usage of erythromycin. And then to manage patients' edema and also circulatory overload, I would put patients on fluid restriction.
How much?
If patient.
How much you going to restrict?
Up to 400 ml per meter square per day.
What is 400 ml per meter square per day?
Insensible loss.
Yes, insensible loss. So insensible loss maknanya loss from your respiration, loss from your GI, loss from your sweat. Kan? Semua ni is 400 ml per meter square per day. It's not up to 400 ml per meter square per day. So it is 400 ml per meter square per day plus yesterday's urine output. So maknanya every day in the ward you assess balik. Urine output yesterday berapa banyak, you add on that. So that is how much you restrict fluid. Okay, alright, lagi?
Okay, we restrict fluid until patients achieve diuresis.
Okay, how much? Urine output how much yang you kata achieve diuresis?
2.5 ml per kg per hour.
What else?
Okay. And then we can also consider to give patient diuretic, for example, furosemide, because patient also is hypertensive. But from that, we can also put patient on salt restriction. However, protein restriction is unnecessary. And if the BP is not controlled with the use of diuretic, we can also opt to give other antihypertensive medication, for example, captopril. We will aim to reduce the systolic blood pressure and also the systolic blood pressure to less than 90 centile. And
okay, siapa ya? Solhi. What is furosemide? Tell us about furosemide. Or tell us about all the antihypertensives that you would consider.
With regards to antihypertensive, I would like to consider a few medications such as nifedipine.
What is nifedipine?
Nifedipine is a calcium channel blocker.
Okay. Dose?
Can't remember. 0.25 to 0.5 milligram per kg.
Okay, fine. Okay. Lagi? What else?
IV labetalol for faster onset of reduction of reduction of BP.
What is labetalol?
Beta blocker.
Okay. Be careful with beta blocker, it can worsen heart failure. Okay, fine. What else?
Metoprolol, beta blocker as well.
Okay. What else? Any other antihypertensive?
Furosemide.
Okay, what is furosemide?
Furosemide is a loop diuretic.
Okay. Where does it act?
Loop of Henle, ascending loop Henle.
It acts at a loop. Okay, fine. Why you want to give loop diuretics?
Most of the time, we give loop diuretics in patients with pulmonary edema.
So So in this patient, would you consider diuretics? If you think it's
maybe not.
If you think
Maybe
it's
I would. Maybe I would consider nifedipine or other antihypertensive, which is, I don't know, maybe.
Okay. Any other diuretics that you can consider?
Spironolactone.
What is spironolactone?
Potassium sparing diuretics.
Okay. All right. Lagi? What else? Any other diuretic? One more.
Thiazide.
Okay. Example?
Hydrochlorothiazide.
Okay. All right. Right. Okay. Anything? So you mentioned diuretics. You mentioned CCB. You mentioned beta blocker. What else?
ACE inhibitor.
Okay. Example?
Captopril. Lisinopril.
So pril just semua. Okay. Lagi what else?
If patient has contraindication to ACE inhibitor, we can consider angiotensin receptor blocker.
ARBs. Example?
Valsartan.
Setan.
Setan.
Okay, fine. Anything else? Itu je. Ada satu lagi group you boleh consider.
Alpha blocker.
Alpha blocker, yes. Dah ada beta, alpha pun nak block juga kan? Example of alpha blocker?
Alpha blocker, alfuzosin.
Prazosin.
Prazosin.
Okay, fine. Okay, let's go. Siapa lagi? Okay, who want to tell us the pathophysiology of post-strep GN? Niswa lah. Kita bagi presenter pula. Okay, come. Pathophysio of post-strep GN.
For pathophysiology of post-strep GN,
Boleh hilang terus lepas bagi penerangan. Excited.
Okay, so for pathophysiology of post-strep GN, there will be a presence of inflammation and also proliferation of glomerular cells due to the immunological mechanism. After the post-strep infection, there will be molecular mimicry, and then producing the antibody and causing the antibody complex deposition at the GBM, matrix glomerular basement GBM, and then causing the inflammatory process to occur. And from this inflammatory process, there will be an activation of the complement system. That's why at this moment of time, initially there will be increase in low in C3 and C4. However, later there will be a low C3 but normal C4. And then this after this activation of the complement, due to the inflammation, there will be a glomerular scarring. That's why this presence of glomerular scarring causing the hematuria to occur. Causing the hematuria to occur, and then causing the impact GFR. And when there is an impairment of the GFR, causing the oliguria as well as activation of the RAS system. And that's why in the PSGN, there will be presence of the high BP due to the RAS activation.
What happens with RAS activation?
What happens? Sodium and water retention. There will be a presence of sodium and salt retention. And then that's why there is presence of edema as well. Due to the water and sodium tension.
Good, bagus. So I would expect at the beginning, if you can say things like, okay, group A strep ni dia ada two strains. Dia ada cardiogenic strain and also nephritogenic strain. So the cardiogenic strains are the one that mainly affected your basically causes rheumatic fever lah, rheumatic carditis apa semua. And this nephrogenic strain is the one that causes renal punya problem. Kan? Okay, and then the pathophysio I think it's okay, it's adequate. Again, if you're going to go for modified long case for your exam, definitely we're going to ask about pathophysio. Sebab this is obviously we have to reduce your continuous assessment punya mark kan. So kita nak kena, sebab tak ada continuous assessment, macam mana sikit dia ada benda kan. So mark kena reduce kan dari continuous assessment, dia akan lebih banyak pada exam, theory exam. And kalau tak boleh buat face to face exam, kena buat modified long case punya style. Modified long case obviously kita akan ask about pathophysio kan. Kalau PMP ke apa ke, obviously kita akan ask pathophysio. Pathophysio post PSGN is among the favorite question yang akan keluar kan. Okay, for that reason, let's hear Shamimi. Tell us about pathophysio of nephrotic syndrome.
For the nephrotic syndrome, it is because of the podocyte effacement. So when there is podocyte effacement, there is increased permeability of the glomerular membrane. And when there is increased permeability of the glomerular membrane, and it will cause protein to be excreted to the urine and cause proteinuria. So the albumin also will be excreted through the kidney due to the podocyte effacement and lead to the hypoalbuminemia. And it also activate the RAS system and cause the sodium and water retention and lead to the edema and hypertension.
Tak berapa best. Zafirah, you wanna try? Pathophysio or nephrotic syndrome?
Yeah, sorry. Okay. Like the Mimi said, because nephrotic syndrome is because of podocyte injury. So there is a large filtration. A large molecule can infiltrate from the glomerular basement membrane. So like protein. So that causes proteinuria. So it can cause when there is protein flow into the urine, so can cause hypoalbuminemia. Next, because of hypoalbuminemia, so there is about reduced oncotic pressure in the intravascular, so and increased hydrostatic pressure. So it can cause the flow of the water into the third space loss, cause edema. And then because of the reduced protein in the body, so the liver will be compensated by producing protein such as lipid protein, cause hyperlipidemia. So
okay, wait. Jazli nak try? You wanna try? Tidur dah Jazli. Better dah Zafirah ni. Better dah. Banyak dah. I just want to hear if you can give another way of presenting your pathophysio.
The pathophysio for the PSGN.
Nephrotic. Allah tidur Jazli.
Sorry. Okay, so for the nephrotic syndrome, the pathophysio. So first, the main principle is the podocyte effacement. So what happened is that there is a podocyte effacement, and on top of that, the podocyte is negatively charged, and the albumin is positively, and the albumin normally is negatively charged. But when there is a podocyte effacement, the podocyte become positively charged while the albumin is negatively charged, so it exacerbates the loss of the albumin. So when there is the loss of albumin, it will cause the hypoalbuminemia. So hypoalbuminemia. So due to the hypoalbuminemia, due to the hypoalbuminemia, there is an extravasation of fluid from the intracellular cell into the extracellular cell. Due to the flow of the fluid extravasation of fluid from intra to extra cellular cell, it will cause the
Rasa Jazli dah pening ni sebenarnya ni. Aklan, Aklan, come. Tell us. Pathophysiology nephrotic.
The pathophysio, based on your previous teaching, we have two theory. We have the underfill and also the overfill theory. So let's talk about the underfill theory first. So first and foremost, there will be podocyte effacement. So because of this podocyte effacement, there will be leaking of the filtration slit. So in a normal situations, as Jazli mentioned that, the podocyte should have a negative charge, and then albumins being a negatively charged particle, normally it will repel one another. But with podocyte effacement, there will be a more leakage of the protein and causing the albuminuria. So because of this, there will be a state of hypoalbuminemia, and there will be decrease in plasma oncotic pressure. And because of this, there will be extravasation of fluid outside into the extravascular compartment, and eventually there will be fluid depletion. Intravascular compartments will be depleted, hence the name underfill. And then another theory will be the overfill theory. Because of the podocyte damage, it will inappropriately activate the RAS system. So because of the RAS activation, there will be water and sodium retention, hence the patients can have hypertension in such presentation. And as Jafira mentioned before, because as a part of the compensatory, so there will be elaborations of protein, lipoprotein from the liver, and also in addition to albumin being lost, the coagulation factor, antithrombin factor C, factor S, and antithrombin 3 will also be lost in the urine.
Okay, so basically, dia ada dekat podocyte tu several things is going to happen. First, the size of the lumen as well is increased because effacement of the podocyte food processors tu, so the size of the holes will increase. So the GBM will become more porous sebab lubang dia besar, kan? So biasanya the large particle like albumin they cannot pass through. Tapi bila effacement of the food processors tu, the size of the holes become large and larger particles can pass through the GBM. Satu, and then change of the ionicity of the podocytes as well. So few things yang happen. Okay, I prefer to hear things like how this proteinuria causing hypoalbuminemia, and then this hypoalbuminemia affects the Starling forces. Kita ada Starling force, ada Starling law. What is Starling law? Starling forces is Starling forces are the plasma oncotic pressure, hydrostatic pressure, kan? So bila hypoalbuminemia reduces plasma oncotic pressure, increases plasma hydrostatic pressure, reduction in fluid from the intravascular goes into the extravascular space. So third space shift of fluid, kan? Okay, that is Starling force. Oncotic pressure, hydrostatic pressure, Starling forces. What is Starling law?
When there is increased venous return, there is stronger contractility of the heart to provide output.
That is Starling law, kan? Increase venous return, increase cardiac contractility. So that is Starling law. Dia macam spring. The more you pull, the more it will go back up. But then dia ada sampai satu threshold. When you reach the threshold, it won't contract well anymore. Macam dilated cardiomyopathy, kan? The more it's dilated, dia dah sampai satu part, dia fail. Okay, alright. So you mentioned about the Starling forces and then third space loss and then causing underfill. So blood pressure is either normotensive ataupun low, and then activation of RAS causing salt and water retention as well. So this is underfill and overfill theory. So nephrotic syndrome punya pathophysio ni, obviously, if you get a case with me, obviously I can assure you Unless your punya history teruk gila sampai kita terpaksa discuss about your history lah. But most of the time, I will definitely ask you about pathophysiology of nephrotic syndrome. And pathophysiology of nephrotic syndrome ni is more interesting to ask in exam daripada pathophysiology of post-GN. So you need to know about pathophysiology. And then when you know about pathophysiology of both things, baru you tahu nak buat apa. So I always see student, I always see doctors as well. They confused. Bila patient datang dengan nephrotic syndrome, edema tadi kan. Siapa tadi cakap? Because fluid overload is edema. Edema is fluid overload. Edema does not mean fluid overload. Edema does not necessarily mean fluid overload. Kan? So sometimes bila you think edema sama dengan fluid overload. Kan? Itu yang sampai kadang kita nak bagi nephrotic syndrome pun nak bagi diuretics lah apa semua kan. What's going to happen kalau you bagi diuretics pada patient nephrotic syndrome? Apa akan jadi?
Hypotensive. Can be hypotensive.
You will kill the patient lah. You will kill the patient. Dah lah dia dah fluid depleted dah sebab fluid semua shift into the third space. So intravascular space dah, intravascular volume dah already depleted. Kan? Lepas tu you pergi restrict fluid pula lagi. So bila you restrict fluid atau you bagi furosemide kan. So what's going to happen? Dia akan jadi lagi, dia akan go into shock lah. Dia akan go into shock. So you're going to kill the patient. Lepas tu understanding pathophysiology is very, very important. In nephrotic syndrome, GFR is not affected. GFR dia normal. In AGN, post-GN, GFR dia affected. Tapi in nephrotic, GFR not affected. Cumanya dia punya GBM dia is more porous. Is more leaky. Itu je. Tapi GFR is not affected. The moment you correct dia punya albumin, urine output should normalize. Kalau post-GN, it takes time sampai dia punya GFR dia recover. Okay. So understand the pathophysiology. And the moment if you get confused with the pathophysiology tu yang jadi macam-macam management pelik-pelik tu. Okay. Alright. Berapa lama dah ni? It's already 1.5 hours. Okay. So overall from Niswa punya presentation, I think history wise is okay lah. I do expect a bit more. I expect her to at least there are a few differential macam liver, nephrotic, those I expect, and I expect a bit more. I always emphasize, okay, you cerita dah chronologically, okay, tapi element of condition of the patient on arrival, that is for me is important as well. Sebab condition of patient on arrival tu, it may signify lots of things. Maknanya sometimes the conscious level at that particular time. So that assessment is different daripada masa you clerk. And then when the day of clerking in relation to day of admission also is important sebab physical findings akan differ the moment you on day of if it's delayed in terms of admission dengan clerking tu. Okay, and then initially you mentioned 2 weeks ago ada rash. I was thinking rash ni macam mana? Maknanya is there any the progression of the rash pun? Sebab mula-mula you didn't actually mention the duration of the rash. Sampai bila physical examination baru you sebut rash tu ada. So baru kita boleh assume okay rash tu for the whole 2 weeks tu still ada maknanya. So because initially I thought okay rash 2 weeks, rash tu dah settle ke ataupun still ada ke atau macam mana, it's not really clear. Sampai you present part physical examination baru we understood that okay the rash is still there. But we still want to know the progression of the rash. Dia start dekat mana, dia pergi dekat mana, dan sekarang dekat mana, sekarang dia makin better ke tak, foul smelling ke tak kan. Sometimes kalau dia ada this crusted ni, sometimes dia ada foul smelling, dia ada pus ke macam mana, ada discharge ke tak, dia WP punya lesion ke tak. So all these things sometimes kita nak kena tahu more. Lepas tu so chicken pox ni satu lagi nak tengok ada lesion lagi tak chicken pox ni, sometimes dia still ada scar dia apa semua kan. I think that's all lah yang I can get. Otherwise I think for me it is quite okay. I think you've covered all the 4 objectives of presenting a case. What are the 4 objectives of presenting any case? The first one is to get to your provisional diagnosis and to confirm, to get to your provisional diagnosis. So your history have covered everything about your provisional diagnosis. The most glaringly masa start slide tu dah tulis post-FGN. Okay, nasib baik tak ada member kata my provisional is post-FGN because she already showed diagnosis post-FGN. Fine. The second objective is to rule out all your differential diagnosis, kan? So I always tell student, bila you start clerking tu, you kena ada at least 5 or 7 differential diagnosis. Sebab you can only ask appropriate questions if you have good differential diagnosis. Kalau you tak ada differential diagnosis, how are you going to ask question? You cannot ask question. Kan? You tak tahu apa soalan nak tanya. You tak tahu nak fokus pada apa kalau you tak ada differential diagnosis. So you need to have good differential diagnosis. And I think you've covered most lah of your differential. Tapi tak banyak. I think out of all semua only 3 ke something yang covered. Tu pun ada few element lagi yang patut you kena mention lah. Okay, and then what is the third objective of presenting a case? To look for complications of the disease. And I think you've looked at the complication in terms of hypertensive crisis, apa semua benda. I think that's quite adequate lah. And then the fourth is complications of the treatment. So if there's any treatment buat, tapi you tak mention treatment, apa buat kat ED? Apa buat kat ED, lepas tu kita tahu dia clerk ni hari apa, so apa dah buat dalam ward. So all these things kita tak berapa tahu. Berapa lama dia duduk kat ED, because duration in ED shows many things. Kalau dia duduk lama dekat ED, probably there's a lot of resuscitation going on. Kan? Tapi kalau dia sekejap je kat ED, tu lain cerita lah. Ataupun kalau dia lama kat ED tapi because tak ada ward, tak ada bed, so dia duduk dekat observation ward dulu, tu lain cerita. Tapi the duration of staying in ED is actually, it may signifies lots of things. Bukan setakat duration, also where did the patient go daripada ED tu. Maknanya dekat dia pergi sampai triage tu terus pergi kat red zone. So it signifies that probably dia datang tu in crisis, kan? Tapi kalau dia triage, lepas tu pergi kat yellow zone ataupun green zone, kan? So probably it's not that bad lah, kan? So where the patient is triaged daripada ED and duration of stay dekat ED tu actually may signify the situation, condition of the patient masa sampai. Especially things like HUS. HUS is usually very bad. Patients with HUS usually presented really sick. So all those things. Okay, alright. I think okay dah kot. Sedang 1 hour 40 minutes dah. Any question? Any question to the examiner?
Last question. Sorry. When we can if we have a case of nephrotic, we can have hypercoagulable state, and they say like we can give in some cases a low molecular weight heparin. Do we give in all cases, or we depend on the situation? Is there any criteria?
It depends on the situation. It depends on patient. I've not seen any of my patient needing any heparin. It's very rare. But can we give? Yes, we can give.
Usually we don't give, doctor.
Usually we don't give.
Okay.
Okay. Speaking about nephrotic, siapa yang tak tanya lagi Hazirah tak tanya lagi kan? Kita tanya dah. Hazirah, okay. Hazirah, tell us, what is how do you define remission in nephrotic syndrome? Obviously, if you dapat nephrotic syndrome with me, I'll ask you definitions. And you can expect already after this what I'm going to ask kan?
Okay, for remission, the definition is negative protein on urine dipstick for 3 consecutive days.
Okay, how do you define relapse?
Relapse, gross edema or proteinuria, 2 or more.
Gross edema. Okay.
2 plus or more for 3 consecutive days.
Okay, how do you define frequent relapse?
Frequent relapse, 2 or more relapse within 6 months of initial diagnosis, or 4 or more relapse within 12 months of diagnosis.
Okay, Anis Wardati, tak tanya lagi kan? Okay, what is steroid dependent nephrotic syndrome? Tak dengar lah Anis. Cakap seorang-seorang pula. Cakap dalam hati je.
Ya tu.
Ah.
Dia dekat dengan aku. Okay, for steroid dependent, when there is 2 or more consecutive relapse, when we taper down the steroid dose within the
Are you sure?
steroid dependent nephrotic syndrome.
2 or
When
more?
we-
Dalam definition dia?
2 or more. When we reduce the steroid dosage, there is 2 or more consecutive relapse within 14 days of tapering down the dose.
Okay, steroid resistant?
Steroid resistant. Steroid resistant.
Sudah mana Anis ni? Tak nampak dia. Angkat tangan, angkat tangan. Ada lagi. Sudah. Mana Anis? Nak call for help ke? Call for help. Bagi nama seorang.
Anissa.
Anissa. Okay. Steroid resistant.
So there is no remission after initial administration of the oral prednisolone of 60 mg per kg per day.
Failure to achieve remission.
For 4 weeks.
After adequate dosing of steroid. Okay. Apa lagi? So steroid dependent, steroid resistant, steroid sensitive. Okay lah, kita dah cover semua dah. Okay. Siapa seorang lagi? Kita semua dah tanya dah? Semua dah tanya dah? Niswa lah, Niswa. Walaupun I know you prepared about PSGN, tak kira nak tanya juga nephrotic ni. Okay. What are the types of nephrotic that you know? Causes of nephrotic syndrome.
Right.
Sudah Niswa ni pening.
Okay. So for nephrotic glomerulonephritis, there is 4.
Nephrotic syndrome bukan nephrotic glomerulonephritis, nephrotic syndrome.
Secondary kan itu.
Okay.
Primary.
Okay. What is the commonest? Janganlah mute kan. Tak boleh tanya lagi. Orang tengah tanya jangan mute. What is the commonest cause for nephrotic syndrome? Minimal change.
Changes.
Okay. So what is minimal change?
Just Anissa lah.
Orang sebut nama Anissa ni. Kenapa? Cepat. Nama telah diseru.
If I'm not mistaken, there is renal problem. However, there's on imaging there was no any evidence of anatomical changes. If I'm
Even on histopathology, you won't see that much changes lah. That's why they call it minimal change. Okay. Any other cause for nephrotic syndrome? So first is minimal change. Lepas tu? Solhi.
Membranoproliferative.
Membranoproliferative. Okay, enlighten us. What is membranoproliferative?
There's proliferation at the membrane of the glomerulus.
Sebab nama dia membranoproliferative kan. So proliferation of membrane. Okay lah, tak apalah, boleh terima. Taklah boleh sangat tu boleh. Aklan, one more. Sebelah Soli dalam my picture ni Aklan. Tapi Aklan dia tukar gambar dia. Nah Aklan.
Yes.
Tak dengar Aklan.
Another one would be FSGS, focal segmental glomerulosclerosis.
Good. Okay. Focal?
Focal segmental glomerulosclerosis. So there will be foci of involvements in the renal. So we must take biopsy adequately because we might miss and we might misdiagnose as minimal change disease. There will be sclerosis of the glomerulus.
Okay, if the patient has FSGS, will the patient respond to steroid?
Poor response, but I'm not sure if but it's poor response.
Usually in FSGS, especially lah, they don't actually respond they won't achieve remission with steroid. And so, any other drugs that we can use for FSGS?
Cyclophosphamide.
Okay, yeah, cyclophosphamide. Lagi?
Azathioprine.
Azathioprine.
Not sure.
Okay. Cyclosporine lah biasanya cyclosporine, cyclophosphamide. Satu lagi. MMF.
Mycophenolate mofetil.
Oh yeah. So very difficult to get that drug. We don't have. I don't think we have it here in UIA. It's very difficult to get even in USM. So basically, banyak kita guna cyclophosphamide and cyclosporine lah, kan? Okay, alright, that's it. 1 hour 50 minutes, 2 hours. This is too long already for me. My brain is frozen already. Any other question? Ask the examiner.
Question in streptococcal, group A streptococcal infection in pharyngitis, we can give IM penicillin G if the patient cannot comply with the oral penicillin V. So in this patient with nephrotic syndrome, post-streptococcal glomerulonephritis, can we give IV penicillin G?
Semula soalan tak apa clear.
In patient with group A streptococcal infection, pharyngitis, we can give IV penicillin G if the patient cannot comply with the oral penicillin B. So in this case, can we give IV penicillin G also, or we can just give oral penicillin?
Okay, my question to you is, why you want to give antibiotic in post-FGN? Kenapa nak bagi antibiotik?
To prevent acute rheumatic fever.
Dia kalau dia dah cause post-FGN is nephrogenic strain, it shouldn't cause rheumatic fever kan? Sebab rheumatic fever is different strain. So binatang yang sama, dia takkan effect both. So dia satu je. Kan? Tuhan pun dia jarang lah bagi you multiple disease. Kan? Bagi satu-satu one by one. Kan? So kalau dia cause nephrogenic, it shouldn't cause rheumatic. Okay. But we've discussed about the pathophysio of post-FGN. So why do you want to give antibiotic?
To eliminate the infection of the streptococcus.
Okay, the thing that I want you to think is macam ni. Okay, if it's pneumonia, for example, pneumonia is caused by the infection itself, causing the inflammatory process, consolidation, is because of the infection itself. But look at the pathophysio of post-FGN. Is it because of the infection? Is it the infection, the bug group A strep yang pergi duduk dekat your kidney and destroy all the GBM? No. What caused it?
The antibody.
Antibody complex deposition. The problem, the disease is not caused by the infection. The disease is caused by the immune response. It's caused by the antibody complex deposition. So that is the reason why. Okay, so when we understand the pathophysio, we should understand that actually And then kita tahu pula dia punya timeline. Biasanya macam mana? Biasanya masa dapat group A strep masa tu ke dia dapat that this nephritic GN? No. It usually happens 5 days after, 7 days after, sometimes 2 weeks after the onset of the Streptococcus infection. Why? The thing that the disease is trying to show us is that the infection does not cause the GN. The GN is not caused by the infection. The GN is not caused by the bug, not caused by the strep. Streptococcus tu tak bersalah. Walaupun dia buat molecular mimicry lah kan. Tapi yang bersalah adalah antibody complex deposition because of the molecular mimicry as well. Kan? Tapi, okay, so if you understand the pathophysio, you will understand that actually in post-strep GN, antibiotic is not essential. It is not part of the management. Tapi dalam PIS protokol ada. Kan? So kenapa kita nak bagi? So mainly, if you ask me, mainly it is to treat the doctor. Sebab doktor ni risau sangat. Oh, mungkin kuman tu ada lagi. Maybe there is some sikit-sikit kuman tu. So might as well kita dah dalam hospital kan, kita bang je lah, kita bagi antibiotik. So that's the reason why. There's no other reason. That is the reason. Because the infection doesn't cause the nephritis. Nephritis is caused by our body trying to fight and then they duduk somewhere and that destroys the kidney. Kan? But the infection itself does not cause. In most situation, the infection has already settled. Kuman tu dah tak ada dah, mati belaka dah semua kuman tu. Kan? So antibiotic is not essential in treatment of post-strep. It is not part of the treatment of post-strep GN. But especially in Malaysia, because post-strep GN is common in Malaysia. If you go to UK, you won't see any post-strep GN. They won't know. My son ada tu masa when we lived in UK, my son had some hematuria apa semua. They don't even know. Doktor sana tak tahu mendatang apa post-strep GN, tak tahu nak manage macam mana. Kan? They don't know. If you go to KL, they have not seen post-strep GN cases for so long. Post-strep GN is only common in East Coast. In Kelantan especially, Terengganu and also Pahang. In other states, it's not common at all. In other states, it's not common at all. Okay, so basically because this disease is common in our side of the world, in our region, that's why we think that probably it's useful for us to just kill off the remaining infection that is still there. Okay, what type of, then we discuss about what type of antibiotic. Obviously, if we think about strep, the best is beta-lactamase lah, kan? Mana penicillin. So penicillin we know that's the best drug, kan? You nak bagi ikut macam mana. Kalau nak bagi IV ke, oral ke, whatever you give. It's okay. It's not a problem. Tapi kalau you give something like IM just to kill off something that is not actually necessary, dia macam overkill juga kan? Kan? Tak pasal-pasal sakit extra just because nak kill off something yang tak sure. Sebab tu oral is ideal because we are not actually macam, kita pun tahu probably bila dah ada GN ni maknanya infection tu dah pass already. Kan? So again, if you cannot tolerate penicillin, you can give other type of beta-lactamase lah. For example, macam erythromycin ni group macrolide kan, erythromycin apa-apa group tu. You can even give first generation cephalosporin for example. All have quite good coverage for Streptococcus. You can even give amoxicillin. Bagilah apa-apa nak bagi. It's alright. Okay, understand? Any other question? Okay, clear lah faham tu kalami. Okay, alright. Okay, I think good presentation. Keep up the good work. I don't know whether sepatutnya today is the decision by the university whether it's actually okay or not for you guys to start your face-to-face teaching in our hospital. Sepatutnya at the beginning of this week the hospital started with surgical orthopedic kan, premier department dekat universiti ni kan. So dia orang start dulu, and then after 3 days baru dia bagi dekat marahin macam pediatrik, ONG ni semua. So tak tahulah. So I hope it goes well. Dalam group coordinator pun professor didn't mention anything. So hopefully we can proceed with our clinical proper bedside teaching lah. The only concern I have is we don't have that many patients. Into the problem there. Actually the whole world, it's not just our hospital. The whole world don't have that many patients in pediatric wards. Kalau you pergi HTA pun, there was a time ada less than 10 patients. The whole ward, less than 10 patients. So we'll see lah, we'll see. I don't know which group I have teaching tomorrow. Okay lah. Alright, I think if that's all, let's end our session with tasbih kafarah and surat Allah. Okay, Assalamualaikum. Bye.
Betul.
Ah.
Nak tanya pasal teaching face to face tu kira tak ada ke esok macam mana?
Ya, your group ke dengan saya?
Tak. Satu lagi.
Ha?
Kita orang G3 tak silap. Kita orang dengan Dr. Ismail.
Dengan Ismail. I tak tahulah. I think dia akan depend pada few things lah. Satunya Prof Mazuki pun tak ada mention mana boleh start ke tak boleh start, dia belum sebut lagi lah. I hope by tonight dia akan finalize kan. Secondnya adalah I don't know how we're going to go about kalau tak ada patient dalam ward tu. Sebab bukan kosong langsung, ada patient tapi surgical patient, ortho patient, seorang, dua, macam tu. But I have my patient who's going to be electively admitted tomorrow lah. That's quite an interesting case. Kalau siapa nak Clark pun ada satu patient akan admit tomorrow. Nama dia Akilah. So dia akan admit tomorrow. Quite interesting case lah if siapa yang boleh masuk dan Clark tu cari patient nama Akilah. Dia patut admit besok, I don't know what time lah. So quite interesting case. So I don't know what we're gonna do macam mana. I seriously don't know. Probably kita nak kena tak tahulah. I don't know. I'm thinking probably I use my son nak ajar developmental assessment ke apa ke. Probably lah kot. We'll see lah macam mana.
Okay, Doktor.
Alright, okay.
Thank you, Doktor.
Assalamualaikum.
Thank you, Doktor.
Doktor.